Hi guys, welcome to Radiology 365 where we try to cover core radiology from cover to cover. Still on the discussion of patterns of lung disease, we are going to be discussing cavitary and cystic lung disease today. A cavitary lesion is the development of air in a pre-existing lesion. So means you may have had a nodule in the lung already, or a mass or some consolidation in the lung already, and now some air has developed inside it. It's basically cavitated. When the wall of this cavity is less than or equal to 4 millimeters, it's mostly a benign process going on. However, if the wall thickness is irregular and more than 15 millimeters, you should be thinking malignancy. Not always the case, but mostly malignancy. When you also have speculations at the outer margins, you should also be thinking of malignancy. By and large, when a solitary cavitary lesion is seen, it's likely an infection or cancer. So this axial CT shows a single speculated cavitary lesion in the left upper lobe. This was a case of squamous cell carcinoma. Other causes of cavitation include tuberculosis, fungal pneumonia, cavitatory bacterial pneumonia. So in this CT, which is a case of post-primary TB, we have massive alveolar consolidation in the left lung with some bronchiectatic changes as well as cavitation, a big cavity in here. The teaching point here is that cavitation occurs in the context of pre-existing disease. So you may have had a nodule, a mass, a consolidation, and then this now cavitates. When we see multiple cavitary nodules, the differentials include septic emboli, which is typically peripheral, vasculitis, including granulomatosis with polyangiitis, metastasis, classically squamous cell carcinoma, but any metastatic lesion can cavitate. But the most common cavitatory metastatic lesion is squamous cell carcinoma. So this axial CT shows numerous cavitary and non-cavitary lesions. You can see some cavitary lesion here, another one here, and we see the peripheral distribution of these cavitary lesions, but there are some non-cavitary lesions as well, and it's bilateral and it has a random distribution. This was a case of polysubstance abuse and septic emboli. Now we shift gears to cystic lung diseases. So a cyst in the lung is an air containing space with a thin wall. That's different from cysts in other parts of the body that is fluid containing. Cysts in the lungs are air containing spaces with thin walls. So when you have multiple lung cysts, some differentials that should be running through our minds include lymphangioliomyomatosis or LAM, which is a diffuse cystic lung disease due to small muscle proliferation of the distal airways. It occurs only in women and it causes uniformly distributed thin-walled cysts in a diffuse distribution. Other differentials include pulmonary Langerhans cell histiocytosis, which features irregular cysts and nodules predominantly in the upper lungs, lymphoid interstitial pneumonia. This one is a rare disease, but it's usually associated with Sjogren's syndrome and it's characterized by lymphocytic infiltrates and multiple cysts as well. You can consider a differential of amyloid, which appears similar to lymphoid interstitial pneumonia. Pneumocystis jirovecii pneumonia also features cysts in its late stage. So in this axial CT, it shows bilateral thin-walled cysts that are of varying sizes and predominantly regular in shape. There's a small left pleural effusion here, and this was a case of lymphangioliomyomatosis. Chylous effusion can be a feature of lymphangioliomyomatosis. Now, when you have a single lung cyst, some of the differentials include a bleb, a bulla, and a nematocele. What's exactly the difference between these entities? A bleb is an air-filled cystic structure contiguous with the pleura. It's very small, measuring less than 1 centimeter. Ruptured blebs, because of their subpleural location, are the most common cause of spontaneous pneumothorax. So in this coronal CT, we see this right apical bleb with associated pneumothorax, which is likely due to the rupture of some other bleb somewhere. Then, still on the single lung cysts, a bulla is an air-filled emphysematous space, also usually subpleural, similar to the bleb, but this time it measures more than 1 centimeter. A giant bulla should occupy at least 30% of the volume of the thorax. So in this axial CT scan of the chest, we see these cystic subpleural areas which are much larger than the bleb that we saw, and we'll talk about this later, but there are some emphysematous spaces within this lung as well, and this was a case of bullous emphysema. So these cystic spaces in the subpleural region are bully, larger than the bleb. Then a pneumatocyst is an air-filled space caused by prior lung trauma or infection. It's usually deeper within the parenchyma than the blebs and the bully. So in this CT scan of a 25-year-old involved in high velocity RTA, we see ground glass opacity in the right middle lobe with multifocal thin walled cysts here, some thin walled cysts here, but there's a bigger one here. In the setting of trauma, the cystic spaces are traumatic pneumatocysts with the areas of ground glass opacity consistent with small pulmonary contusions. On follow-up imaging, these changes resolved later on, about 2 months or so. And this is to be expected in the case of traumatic pneumatocysts. Once the inciting condition goes away, the pneumatocysts would also go away. So if it were a pneumonia associated pneumatocyst, once the pneumonia is treated, the pneumatocyst should also go away. So before we go on with the characterization of cysts, it's important to determine whether what we are looking at are actually cysts, because sometimes emphysematous changes can be confused for cysts. So let's note that cysts have walls. If it doesn't have a well-defined wall, then it's likely not a cyst. You may see some areas of increased lucency different from the normal lung parenchyma, and you may be thinking there are some cystic changes or pneumatocysts in there. However, when you look closely, you would realize there are no well-defined walls. Then we should be thinking of emphysematous changes. And sometimes too, if you were to be able to scroll through the image, you would see that within the emphysematous changes, the bronchosculature would appear as a central vessel, as a white dot. So here we have this white dot here. If we were to scroll through, we realize it's actually continuous with the vasculature. It's called the dot sign in emphysema. Cysts will not have anything within them. So in this axial CT, we can see multiple focal lucencies all through the lung. We can see some areas of normal lung parenchyma as well, which appear of higher attenuation than the emphysematous areas. Someone may argue that these linear opacities are the wall of the cyst in quotes, but they are actually the walls of the secondary pulmonary lobule. So we still see the septi of the pulmonary lobule, the secondary pulmonary lobule, as well as the vasculature crisscrossing through the areas of increased lucency, but no defined wall of a cyst, which would be quite rounded. All right. Thank you very much for your attention. I hope this has been helpful. The next thing we'll talk about would be trying to understand fibrotic changes in the lung. See you then.